oocytes, and the primary oocytes are contained in follicles, right? We have the primordial follicles all around the periphery and the cortex of the ovary, and then those primary follicles, those primordial follicles develop into primary follicles, and the primary follicles start to stack up those granulosa cells. They're cuboidal epithelial cells, so you actually get stratified cuboidal epithelium that is surrounding that little primary oocyte. Is a primary oocyte diploid or haploid?
Diploid.
Diploid, right. What does diploid mean?
240.
Give it a little, let's get a little more specific.
2 sets of 23 chromosomes.
46 chromosomes. Where do those 46 chromosomes come from?
Mom and dad.
Mother and father. 23 from mom, 23 from dad. Are those chromosomes duplicated chromosomes?
No.
No. Right. And remember that those chromosomes are in long strands in your normal somatic cell, right? They're just long stringy strands of chromatin. And those chromosomes then undergo, they enter into meiosis I in the primary oocyte. What happens during meiosis I?
Secondary oocyte.
Nope, not yet. What happens during primary meiosis I?
Arrest in prophase 1.
They are arrested in prophase I. What does that mean?
They don't continue.
They don't continue on. What happens in prophase I? Lots of things happen in prophase I, by the way. It's a really important step in the whole process.
Crossover.
Crossover, what's crossover mean?
The chromosomes exchanged gene.
Yes. So we have these long strands of chromatin, and then those long strands of chromatin, they actually condense. Because you can't have these long strands trying to find mom's version, dad's version, so they have to condense. They have to curl up. And once they curl up, then chromosome 1 from mom and chromosome 1 from dad find each other. And they snuggle up. And crossover occurs. They swap pieces, usually from the ends of the chromosomes. And, of course, they've already duplicated. So the first part of chromosome 1, prophase 1, is duplication of the chromosomes. So you have sister chromatids. Then you form something called a tetrad. And the tetrad is mom's duplicated chromosome, dad's duplicated chromosome, and pieces are swapped. Then they line up along the metaphase plate. Are all mom's version on one side of the metaphase plate and all dad's on the other side?
No.
No. Do you know what that's called? Independent assortment, exactly. Then we divide, right? We produce secondaries. In the case of females, we produce one primary oocyte and a polar body. But that primary oocyte is actually a secondary oocyte, right?
Mm-hmm.
With the polar body. This happens when? When does that happen?
At what point in the cycle?
Yeah, at what point in the cycle? So you got all these follicles that are developing along the edge of the ovary.
Follicular phase?
So the follicular phase, yes. And what I'm saying is that this secondary oocyte only becomes secondary right before ovulation.
Okay.
Right, and that polar body is carried with it. It pops off the ovary and then gets carried up the oviduct and on its way. So we talked about the ovarian cycle. We talked about the development of the follicles, the first 15 days, 14 days. And then the follicle ovulates, and the second 14 days is the luteal phase. Right, you go your follicular phase, ovulation, then luteal phase. Why is it called the luteal phase? Because the corpus luteum is created. What's the corpus luteum?
Endocrine structure.
Scar tissue. It's not quite scar tissue yet. What did you say? It's a temporary endocrine structure because it's going to continue carrying on the production of progesterone and estrogen. So the luteal phase is, the whole purpose of the luteal phase is to support the development of the uterine lining. The first part of your ovarian cycle is linked to your uterine cycle or your menstrual cycle. The first day of menses, first day of menstruation, is the beginning of the cycle. Menstruation occurs 3-4 days, sloughing off the uterine lining. Then you have something called the proliferative phase. And the proliferative phase is occurring at the same time as the follicles are getting sorted out. Estrogen and progesterone nice and low. Y'all know what I'm talking about? Kind of a relaxed period, right? You can breathe, everything's fine. I don't know about you, but as I got older, the tension just got worse. So maybe you're not noticing if you're 18, 19 years old, but you hit 30, 35, then 14, day 14, right? You ovulate. Well, why did you ovulate? You ovulate because luteinizing hormone spiked. And at the same time as you ovulate, that corpus luteum then is created, and your progesterone level goes, estrogen here, progesterone up here.
Because the corpus luteum is
Producing that
a lot of
progesterone,
it,
estrogen.
right?
Yep,
Okay.
yep. So you got this flood of progesterone, and there's a purpose for this, because progesterone is going to prevent any more implantations can't happen. And we'll follow through with that as we talk further. So your ovarian phase, follicular phase, then luteal phase, goes with your uterine cycle, I should say ovarian cycle. Your uterine cycle is proliferative phase and then secretory phase. And that's what we're going to start talking about now, is the uterus and how the uterus works in conjunction with the ovaries. Okay. So understand how the ovaries are working. They're producing follicles all the time. Each month, one of those follicles is selected. It's like Dr. Toyota calls it, it's like a horse race. And one horse reaches the finish line first. And that's the one that had all of the attention showered on it. And by attention, I mean that that follicle received extra progesterone and estrogen because it got extra receptors. So it got upregulated. Yeah. All right, so now we want to talk about the uterine tubes. I think you're all familiar with these fallopian tubes or oviducts. And they start here with these little finger-like structures called the fimbria. That, remember I told you the ovary is never attached to the fimbria. It's just sitting in a little pocket that the fimbria creates. My fingers are the fimbria. Okay. Oh, there we go. And so we have our fimbria. The fimbria is part of this beginning of the oviduct called the infundibulum. The infundibulum leads to the ampulla, and the ampulla leads to the isthmus. And in most of my images, I think it's best to really think about the isthmus as this narrowing, this region of the oviduct that's entering into the uterus, so that you don't get confused, right? If you're in the exam, the lab exam, which I know that's where all your brains went just then, if you have a sticker right here, you're going to call it the ampulla. If you have a sticker out here in the the funnel-shaped part, it's the infundibulum. If that sticker is right near the end of the oviduct, beginning of the uterus, isthmus. Because the definition of isthmus is a narrowing channel. All right. So we have the infundibulum, we have the ampulla and the isthmus, and apparently most fertilization happens in the ampulla. So the fimbria pull that oocyte into the isthmus or the infundibulum and send it down the ampulla. And remember that our oviduct is lined with ciliated columnar epithelium. And so, just as an aside, because I've been kind of, lax about this, you want to remember that these are not simple columnar, they are ciliated simple columnar. And the cilia is important because it's what's driving the movement of that oocyte down the length of the tube, as well as the peristaltic action of the smooth muscle. Yeah. Same thing with the vagina. When we talked about the vagina, you want to remember it's non-keratinized because we have two kinds of stratified squamous, right? It's non-keratinized stratified squamous, not just stratified squamous. But again, I gave you credit on your lab quizzes, but you got to remember that we have distinctions. So our uterine tube, simple ciliated columnar, and that is very important for moving that secondary oocyte along. Is that secondary oocyte diploid or haploid?
Haploid.
It's haploid. It's also carrying with it, by the way, that polar body. Because that secondary oocyte is actually wrapped up in a zona pellucida, that protein layer, and the corona radiata, that set of granulosa cells that's surrounding the outside of it. Okay. While it's traveling down the tube, it's being nourished. It's being nourished by secretions from those columnar epithelial cells, those ciliated columnar epithelial cells, and driving that, supporting that oocyte and the sperm as they travel toward each other, as they try to meet each other. So the uterus, of course, is a very thick, muscled structure. It's smooth muscle. We don't have to think about moving it. And that is important because that smooth muscle, when it gets extra stretched, is going to start contracting. Because that's what smooth muscle does, right? You stretch it, it wants to contract. It's battling that stretching. Very thick muscular wall. And remember that the uterus has a muscular wall called the myometrium. It has a lining called the endometrium, and it has a surface covering called the perimetrium. Right? Myometrium, endometrium, perimetrium are the three sections of the uterus. It's sitting it is sitting above the bladder. The uterus is sitting above the bladder. And wait till you see what happens to the bladder when the fetus is 9 months old. Poor woman. There's no room for anything in that abdomen, except for a little bit of urine. That's why pregnant women pee a lot, because they got no place to store it. So it's typically tipped forward, and it says here it is anteroverted position, right? Tipping this way, a little anterior and a little superior, as it says, to the bladder. It has a narrowing section right here called the cervix, and the cervix has two openings. There's an external os at the inferior aspect of the cervix and an interior os at the superior aspect of the cervix, and the cervical canal is situated between the two. And the cervix is a really important structure because the uterus is sterile, but the vagina is not. And so the cervix produces a cervical plug, a mucus plug that is thick and prevents anything from traveling up into the uterus on a daily basis. But come menses, it thins out and allows for that menstrual flow, but it also allows for sperm to get up through. So in both cases, it's important for thinning out. Once it's carried away, it then reforms for the next month. That's what the cervix is about. We've got the endometrium, you have our myometrium, and our perimetrium, all three layers of the uterus. Notice that this is kind of thick, right? That's a thick set, that's 10% of the overall, it's quite thick. And that's because this endometrium is going to be receiving that embryo. And that embryo is going to be burrowing its way through that endometrium until it hits the myometrium. And it's the endometrium that grows. We looked at it in lab. We have a functional layer strata and a basal strata. And the functional strata is the part of the endometrium that's sloughed each month, unless we need it. So again, we have big uterus, we have a lumen, we have endometrium, myometrium, perimetrium. Here's our cervix, external os, internal os, cervical canal, lumen of the uterus, fundus of the uterus. This is the rounded portion of the uterus. We have the body of the uterus, cervix, and that leads to the vagina. Broad ligament, we already know about. The broad ligament is holding all of this in some, because it's sort of suspended. Right, the broad ligament's like this. Ovaries, uterine tubes with the uterus in the middle, kind of held in this fashion. It's a little tipped forward, laying down. The uterus, the uterine wall, the myometrium, super heavy blood supply. Uterine artery here, vaginal artery here, plenty of blood being delivered to the uterine wall, via especially the uterine artery. And this uterine artery then branches into what we call spiral arteries. And these spiral arteries are the ones that feed that endometrium. And each month when that sloughs, it sloughs in part because those spiral arteries have receded. And so the cramping that a woman might experience during menstruation is because those spiral arteries have retreated. So there's that feeling of them kind of being disintegrated. Yeah,
I thought it was contraction of the muscle trying to get rid of the endometrium.
that may be a little of it too, but in general, they believe that this is the retraction of those spiral arteries that can lead to those. Yeah, yeah. I know. All right, so we have our layers. Remember the stratum functionalis and our stratum basalis. Here's our nice linkage of all of our different cycles. We've got the ovarian cycle, the menstrual cycle, and the uterine cycle, right? So we have our follicles developing, ovulation at day 14, corpus luteum created. Corpus luteum's created. It's leading to an increased production of progesterone and estrogen. And this increased production of estrogen and progesterone, you can see, leads to, from the proliferative phase to the secretory phase. And we call it the secretory phase because we have all these uterine glands that are going to secrete all of the contents of those uterine glands, specifically, and the one to think about most is glycogen. And glycogen is there to support this dividing, this rapidly dividing embryo. Gabby, what did we decide this morning we were talking about?
Between zygote and embryo?
The date, the time frame. Remember, by day 3, the embryo has divided so much that it's now a solid little ball of like 64 cells.
Mm-hmm.
Yeah, in 3
So the
days.
zygote was before cleavation, you said, and then once it's cleaved, that's the embryo.
Mhm.
And then when it has all those blastomeres, then it's
Then we call it
become
trophoblast.
what's
It's still
it?
an embryo.
A morula?
Oh, morula in between.
Yeah.
Yep. So, any of you who have experienced this tension that you feel, yes, tension, second half of your monthly cycle? No?
I mean, yeah.
Well, let's be honest here, because, no?
I just don't have.
Yeah, I'm curious to know, how many of you experienced this tension?
I feel like it is a pretty like well-known thing. Like the luteal phase is like known as like the worst part of your cycle.
Here's the luteal phase, right here. This is your secretory phase. This is where you're building up your uterine lining. It's the progesterone that
Yeah.
gives you that.
It kind of builds up.
It's an evil hormone. Evil hormone.
Right, before your period, right?
Yeah, before you menses, before you start
Oh yeah,
bleeding.
I'm like,
Like when you're
going
feeling.
Yeah, no, you guys, right? Jonathan, Tyler, have you noticed there's a little bit more tension with Kayla? Just a wee bit. He's being really judicious right here.
It better
Jonathan,
be.
no, have you noticed? You have a partner? Does she get a little, partner get tense? Yeah. They're all being kind of, seriously, this is it. This is why women and men at that phase of each month, there might be more arguments,
Yeah.
right? And it's because of this hormone. That's my whole point, progesterone. So, the uterine menstrual cycle, okay, it occurs, right? Same time, 28 days. Some women are a little longer, rarely shorter, but it can also happen. But generally speaking, it's a 28-day cycle. And the first day of your menstrual cycle, of menses, of bleeding, is the first day of the cycle. And the reason that you are bleeding is because you don't have an embryo implanted in the wall of the uterus. There's no need for the lining of the uterus, and so it sloughs off. And you start back again. You slough off, you go proliferative phase, so you have like, a couple weeks here, feeling pretty good. Week and a half, yeah.
And why do some women, like you said, when they're pregnant, still menstruate? Because I've met quite a few women who
Yeah, I
said
don't-
they menstruated through a lot of their pregnancy.
Yeah.
You know? Why? Do
So
you know
must
why that is?
something wacky with the hormones. That's my only guess.
Yeah, well, the hormones do go totally crazy.
Yeah.
So it makes sense.
Yeah, and Michaela, you want? Thank you. She's on it, man. She's on it. Okay. Yeah, I think it's hormonal. It's got to be hormonal. Gotta be. All right, so we have these spiral arteries that have worked their way up to, and they're feeding that endometrium. They're feeding that functional layer, and they're feeding all those cells to make sure that those cells are intact, so that when the embryo implants itself, then the blood supply is there, and those uterine glands are available. And the uterine glands are really important because we have this rapidly dividing embryo, and I talk rapidly dividing because you start out with one cell and 3 days later you got 64 cells. That's rapid division, mitotic division. So we have all these spiral arteries, they're going up and feeding that stratum functionalis, and unless there is implantation, at the end, after the secretory phase, then you're going to slough that off. And those spiral organs, they recede. And they believe, from what I understand, is that that sloughing off and the constriction of those spiral arteries means that you get that cramping. Now, there could be some cramping from the uterine wall as well, which may have the same response because of the blood supply
Right?
that's being receding.
Yeah.
They probably
interesting.
feel a little different, you know what I'm saying?
Because there's like the pre-menstrual cramps, and then
yeah.
there's menstrual cramps themselves, right?
Yeah,
It
so all of
seems
that would
like
have to do with those,
the pre.
because their pre would be pulling back.
Yeah.
Yeah.
Mm-hmm. Mm-hmm. Quite a bit, right? 80 mil, that's significant volume. Not all blood, there's other fluids involved with it. And then you might have wondered, why doesn't it clot like all blood does? Well, that's because there is a protein, fibrinolysin, that prevents that clotting from happening. So that's part of the process.
Oh
Yeah, right? Oh, I never thought of that. So the proliferative phase, of course, is going to happen after menses, right? After you menstruate, then you've got proliferative phase. And then it goes just day after day after day. So day 14, you're still feeling pretty good.
Feeling
Still feeling
extra
pretty
good.
good, but no, my God. Everybody deals with that differently. And I remember some anxious days. Tension. Anxious and tense. But that's progesterone for you. Yeah. Proliferative phase, keeping the building up of that endometrium, making sure that that endometrium is available for an implanting embryo should the embryo come along. And that's, in part, estrogen triggered. So you need the estrogen to continue building the wall as well as progesterone. Then we have the secretory phase. And the secretory phase is all about these uterine glands. And the uterine glands are all about supporting that incredibly rapidly dividing embryo that may be implanted in the wall of the uterus. When it gets planted in the wall of the uterus, then it's going to need some nourishing. And there is nice glycogen within that uterine gland secretion that's supporting the embryo. There are other things included in the uterine gland secretion. And I'm pretty sure I added the note here. Yes. They also secrete, as you see here, some amino acids, some proteins and lipids, ions. What kind of ions do you think would be important? Potassium, sodium chloride. Yeah, all of those basic ions that we contain in all of our cells. Because we're making new cells. Lots and lots and lots of new cells. We haven't differentiated yet. We just got this ball of cells, all with the same job, make more. Enzymes, hormones, growth factors, proteins, transporters, all within the uterine gland secretions. Making sure that that embryo, the potential of that embryo, has something to work with. That is all within that functional layer. So remember we looked at the functional layer, and then we had the basal layer. That basal layer stays behind, and then we build up again for the next proliferative and secretory cycle. Follicular phase, luteal phase. Nice and low, slough this off, nice and relaxed, and then boom, 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 progesterone, estrogen, and our secretory phase builds and builds and builds until no implantation, great. We don't need it, we're getting rid of it. Implantation, great, we got stuff to take care of that, the developing embryo. We got all the things we need. A nice warm body called a uterus, all the things we need. So this semantic sync animation is a good one. It goes through all the cycles. Again, well worth your time to look at it when you have time. It's in our show. Has anybody looked at it yet?
Mm-hmm. Yeah.
Yeah, it's accessible, right?
Mhm.
Good. From the uterus. So we talked about the ovaries, talked about the uterine tube or oviduct, talked about the uterus. From the uterus, we go to the vagina. The vagina is that dual purpose structure. So one-way street out for the menstrual flow, one-way street in for sperm, for copulation and sperm, the delivery of sperm. It has, in little girls, a lining that is kind of strange. It's cuboidal epithelium that lines the vagina in young women, little girls, until you reach puberty. Once you hit puberty, it then transitions, and it converts to non-keratinized stratified squamous.
Cuboidal is mostly for secretion, right? I wonder why it's cuboidal.
Simple cuboidal, nice, simple epithelial lining. So they got to keep it moist,
Okay.
right? It's a mucous membrane.
Sure.
Yeah.
So the uterus is sterile, and the mucus plug stops, bacteria and things like that. But could bacteria hitch a ride on the sperm?
For sure. But the vagina, pH 4.
Okay. So
There's a tamping down of pathogens just by the nature of the beast.
Sure.
Yeah. But yes,
Or
certainly.
like yeast and bacteria.
People can get
I suppose
endometriosis.
STDs, right? Oh, endometriosis. That
Right?
could
You
be.
get inflammation and infection of the uterus.
Right.
But now, so if you're thinking sperm getting through just any old time, that doesn't happen
Right. The mucus plug.
because
stops
the mucus
it,
plug
right.
stops them.
And the cervical mucus.
And that cervical
Thins
mucus stays
during
until
ovulation.
you're going to menstruate,
Right.
right? Because it
So
has
it's
to
like,
be
well,
able
let's
to.
let this out.
Yep,
And then,
yep.
Okay.
Mhm.
Okay,
And actually that cervical plug, as it thins, those strands of mucus serve as a route to carry sperm up into the uterus.
Yeah. Yeah.
So you could have, the potential is there, for sure. But that sperm is kind of clean,
Ish.
kind of. Totally clean, totally sterile. What else? What else about the vagina? So the vagina has, in the inferior reaches of the vagina, you have folds, the rugal folds of the vagina. What else do we want to talk about? It is stratified, non-keratinized, stratified squamous epithelium. The vagina is at the beginning of the vaginal orifice, and the urethral orifice is just anterior to the vaginal orifice. The vagina is bound on two sides by the labia, also known as your part of the external genitalia. The labia majora, the labia minora. Labia majora may have hair, labia minora does not. The mons pubis is a structure that is specific to females, especially because of the fat pad that's sitting underneath the mons pubis, which has to do with impact, protection from impact, because you have a pubic symphysis right underneath there too. Vestibule is just inside the labia minora and leads to the vaginal orifice. We have a clitoris, which is synonymous to the glans penis, and the clitoris has a prepuce, a hood that covering it. And we saw the clitoris in lab that is way more extensive, right, than the little knob that you're led to believe is the clitoris, because the clitoris actually has the two roots as well. It's constructed very much like a penis, much smaller in its size. On either side of the vagina itself, you have some very important glands and structures. You have these two vestibular bulbs and two vestibular glands. The two vestibular glands produce a lubricating solution fluid, which is to aid in copulation and intercourse. And so too are the gland, or those bulbs. These bulbs are actually capable of engorging with blood. And when they engorge with blood during copulation, during intercourse, that adds to the stimulus of the penis. So the fluid from the vestibular glands makes the vagina nice and fluid, slippery, and the bulbs aid in the stimulus of the penis itself. And these are all going to get active during sexual intercourse, during the excitement phase. So females have the same kind of experience with engorgement of blood as males do. Slightly different structures. The labia, both labia, majora and minora, they get engorged with blood. They get to the color of almost purple in some women. And this is leading up to a discussion about the sexual response. So remember I told you about Masters and Johnson, these two people that they watched a lot of people having intercourse. And they came up with these standard phases of intercourse response. So the first thing that happens is you get this hyperemia of the labia. And that vestibular gland produces the vaginal secretions, so you get a nice slippery vagina. And then the uterus, this is kind of fascinating. The uterus changes position, it tense during the plateau phase. So what they mean by the plateau phase is the uterus actually comes forward like this. So it's laying right next to the bladder, then it backs off during the excitement phase, and then it tenses. And as it pulls up, it retracts the cervix, and that makes more room for the penis to deliver sperm, and then the cervix is dipped into that sperm during orgasm. So that sperm has the best chance of getting up through the cervix and into the uterus. So we have the unstimulated, everything's normal, where everything's supposed to be laying. We have excitement, where the uterus starts to stand, and it brings the cervix up, it expands the vagina, and then you get your hyperemia of the labia, and then you have the plateau phase, where it literally just pulls itself right up like a tent, which pulls the cervix up, makes more room for the sperm, and the penis delivers its sperm, and the cervix then is dipped into that sperm during orgasm. After orgasm, back to normal resolution. And that's female uterine anatomy. A little bit about breasts. Mammary glands are part of breasts. Breasts are a combination of mammary glands, adipose tissue, and connective tissue. The breasts are sitting above the pectoralis muscles. We have a big suspensory ligament that's holding it in place, the adipose tissue that's wrapped around these lobes. Here's a lobe, here's a lobe, here's a lobe. And the lobes are comprised of lobules, and each lobule is containing alveoli. Where have you heard the term alveoli before? In the respiratory system, right? You have the alveoli, those little air pockets. But in this case, they're not air pockets. They're actually filled with alveolar cells that make the milk. And the milk is made by apocrine secretion. And the glands are considered apocrine glands. If you remember what apocrine secretion is, this was 231, a long time ago. We had merocrine secretion, apocrine secretion, and holocrine secretion. Merocrine sweat glands, just sweat being excised out of the glands. Apocrine secretion, little pieces of the cytoplasm wrapped around the milk and delivered. That's apocrine secretion. And then holocrine secretion was your sebaceous glands where they explode And they have new cells, stem cells that are making those cells all the time to build new glands. Yes, so we have apocrine secretion via apocrine glands. And while a woman is pregnant, these glands continue to make milk. And as long as a baby is nursing, these glands continue to make milk. What kind of feedback is that? Positive feedback. So there's another reason, another area where we have positive feedback. So it depends, of course, on the female as to the degree to which they say how large these glands get, right? How large an individual's breasts develop, but all of them contain the same structures. Some of us have more fibrotic tissue in our breasts than others. Some really fatty, me not so much. I have more fibrotic tissue and little cysts. And so I've had a mammogram every year since I was 30. Every year. Every year I get the same notice. Your breasts are fibrotic and it's hard to see. Okay, thanks. So let's see what else we want to talk about here. This is all, we have the worst model. I apologize for the model that we have in lab, but we do with what we've got, right? So you're going to remember that you have this lactiferous ducts bringing that milk from the alveoli to lactiferous sinuses, little inflated areas that store that milk. All of that milk is delivered to a nipple. The nipple is surrounded by a darkened structure called the areola. The nipple is especially sensitive, lots of receptors, and the areola is, they think that the areola is darker because it sort of directs the baby to the nipple. That's what they believe. There is plenty of sebaceous glands around the nipple, and that makes sure that they stay nice and supple, and lots of sensory structures. And as you can see here, touching the nipple, right, nursing off the nipple signals the release of oxytocin and prolactin. Prolactin for more milk production. And then oxytocin, what's the oxytocin about?
Bonding.
Yeah.
So you get so emotional.
Oh, it
Yeah.
also helps stimulate the production of milk, right?
But especially the bonding piece. Yeah. Yes, but you're right. Milk production. What else? Oh, the next thing to talk about is gestation. So we have two new terms for you. Gestation is pregnancy. So when you have a friend that's pregnant, you can say, how's gestation going? And then you can ask, when's parturition? Because that's birth, parturition. And then you can, just toss those terms around and make yourself feel good. Right. So we have pregnancy that's known as gestation. It's a 9-month term for building this new body. It can be lasting from 280 days or 266. It sort of depends on when you start counting. Do you start counting from ovulation to conception, or do you start counting from the last menstrual period? 40 weeks to 38 weeks. It doesn't matter. It's basically the same amount of time. There are 3 trimesters, first, second, third. The first trimester is absolutely the most critical because that's when all of the division and the creation of the new systems is happening. The nervous system is the first, and then the cardiovascular system. And those two, of course, can be seriously impacted by mutations and insults. And when I say insult, I mean, exposure to some horrible radiation or some chemical or something that's going to impact the development of that developing fetus, embryo. Yeah. The second trimester, third trimester are all about building the body, just laying on increased cell division, laying on the muscles, laying on the fat, building up to the time when that fetus can survive on its own. As this says, many hormones involved, and that's what we're going to talk about next. Some terms that you'll hear. I don't use this term conceptus very often because it hasn't been part of my introduction to this whole process, but you can see the term conceptus really pretty much refers to everything that's involved in the development of a new body. From getting fertilized egg or producing the ovum to the zygote becoming an embryo, An embryo is defined as anything up to the end of week 8 of pregnancy. So the first 2 months, you would refer to that structure inside the uterus as an embryo. At the end of 8 weeks, it becomes known as a fetus. Fetus from week 9 until birth. And birth can happen, right on time, or it can be early, or it can be a little late. Sort of depends on the individual again. We refer to our babies as neonates, and then as infants, and on through. And we'll talk about developmental phases when we get there next week. A couple of hormones for you to pay attention to. This is an important one that you all need to know about, because the vast majority of this room are female. This human chorionic gonadotropin is going to start being released. Where does it come from? The trophoblast or the blastocyst. Now let me explain what those terms mean. We have a zygote. This is a single cell that is the result of the sperm fertilizing the oocyte. Once that secondary oocyte is fertilized with the sperm, it finishes meiosis II. So it extracts a second polar body. It now has one set of chromosomes, completely different set of chromosomes than what the primary started out with. This set of chromosomes, just 23 in the secondary oocyte, now has another set of chromosomes delivered by the sperm. Because the sperm made its way in, dropped off its head, the rest of it was sloughed off. Because that's what the sperm is, it's a delivery of DNA. Now you have these two things called two pronuclei. Female's nucleus, sperm's nucleus. They mix, it's called amphimixis. Now we have one nucleus with a whole new set of 46 chromosomes, completely different genetic combinations. This cell with one nucleus is called the zygote. The zygote begins mitotic division from one cell to 2, 2 to 4, 4 to 6, 4 to 8, 8 to 16, 16 to 32, 32 to 64. Now you have this little ball of cells, and we call this a morula. This little ball of cells is going to start to hollow out in the middle. The cells in the middle are going to start producing fluid, and the fluid builds and builds and builds, and it expands the entire structure. When we get this hollowing out in the center, we call this whole structure a blastocyst. The definition of a cyst is a fluid-filled balloon-shaped structure. Yep. So we have blastocyst. The hollow part in the middle is called the blastocele, and then this is the most amazing part of all. The outside of this blastocyst is called a trophoblast, and inside the blastocyst is a set of cells called the inner cell mass. And the inner cell mass is the new you. The trophoblast, the outside of it, is all about supporting the inner cell mass, the new you. Yeah. And this thing has burned itself into the wall of the uterus. By this point, it's in there. It's called implantation. So, week 4, that blastocyst of the trophoblast starts producing this hormone, human chorionic gonadotropin. And this is the hormone that is used to detect early pregnancy. So those early pregnancy tests, the urine tests, they're picking up that hormone. As early as 8 days in, 8 days in, this is week 4. As early as 8 days in, we're going to see some of that human chorionic gonadotropin being produced. Get a good peek of it, and at the same time as this human chorionic gonadotropin is present, because we're pregnant, right? This is being produced by this trophoblast in the blastocyst, and it's important because it's stimulating the corpus luteum to continue producing progesterone. Notice that our estradiol and progesterone is kind of slow in the early parts. That's because the placenta has not been fully established. But once the placenta gets fully established, like around week 12, then the placenta takes care of this estrogen progesterone. And we need the estrogen progesterone to support the wall of that uterus to continue to hold that fetus in place and to support the placenta. So the placenta gets in place. Estrogen, why is it important? Well, because it's going to develop these structures. It's going to help develop the uterus, keep the uterus going. The external genitalia, mammary ducts, breasts, all of these things are important because eventually they're going to be in need. We're going to need mammary glands producing milk. We're going to need a strong uterus that's holding this whole thing in place. At the same time, so later on during pregnancy, right out here, see our estrogen levels are quite high. And it says it relaxes the pubic symphysis and sacroiliac joints. What's that all about?
Birth.
Birth, right? Yeah, you got this restricted region.
You can deflect some of it.
It's amazing, amazing. It suppresses gonadotropin release. What's that mean?
So we don't get another baby.
So you don't get more FSH and LH going on at the same time, right? Because gonadotropin is stimulating the pituitary to produce FSH and LH. Don't need them right now. You've got enough to worry about.
Oh my God, can you imagine?
Can you imagine? So women have actually gotten pregnant once and then within the same month get pregnant again. Any number of things can happen, right? We're just talking baseline, sort of what you expect the norm to be.
I was wondering if a polar body could ever get fertilized because it goes down there.
It could get fertilized, but there's no machinery to carry on.
So it just.
There's no mitochondria, there's no Golgi apparatus, there's
all
no
of-
organelles.
There's no cytoplasm.
No organelles.
Yeah.
No organelles, you can't make a
So
body.
maybe it routinely gets fertilized, but
They
it
might.
just, gets reabsorbed.
And there's this thing about whether it's two polar bodies produced or are there four polar. So some people think the polar bodies divide.
Huh.
We're not going to worry about that.
Doesn't matter.
We're not going to worry about
Yeah.
that. We know one polar body is produced during meiosis 1, second polar body is produced during meiosis 2.
That's what we need to know.
That's what we're sticking with.
We're gonna be.
Yeah. So then we have progesterone, the evil hormone. Why do we call it evil? Well, you saw what happens. And it doesn't affect everybody. Progesterone's important because it proliferates the production of decidual cells. The decidual cells, as you'll see when we get to development, are part of the trophoblast. There's a cytotrophoblast, there's a syncytiotrophoblast. The syncytiotrophoblast is going to ultimately become the placenta, and the cytotrophoblast is going to become what we know of as a decidua capsularis. There's a decidua basalis where the placenta is attached to the uterine wall. There's a decidua capsularis, which is the endometrium that's surrounding the outside of this developing fetus. And then there's the decidua parientalis, which is the wall of the uterus that's not involved with anything. It's just the wall of the uterus, endometrial wall. So we have progesterone that is working with these decidual cells, essentially supporting the blastocyst. What's the blastocyst? That ball of cells that we're calling an embryo, the inner cell mass and the trophoblast on the outside. It suppresses uterine contractions. Why is that good?
So you don't push out.
So you don't push out your new
Your
embryo.
blastocyst.
Yeah, all this work to make the embryo, you want to keep it, right? Stimulates the proliferation of mammary acini. Now, I didn't mention the acini, but the acini are within the alveoli. So the little cells that are making the milk are within the alveoli in the mammary glands. We use progesterone in a lot of these contraceptives. Why? Because it suppresses uterine contractions. It also promotes the suppression of the gonadotropin. That's the part that's most important for birth control. If you're suppressing the gonadotropins, no FSH, no LH, no stimulus of the follicles. Right? Yeah. Yeah.
So I know that there's some people that have problems with contraception because there could be a fertilized egg, a blastocyst, and it's preventing.
Yeah,
so,
that's why uterine devices, what do we call them? Oh my God.
IUDs.
IUDs, thank you, yeah, are, essentially banned in some states. Let's not go there.
So, but I'm just wondering, so it.
Because you can have a fertilized embryo traveling down to the uterus, but your IUD prevents it from implanting.
But so then, and then the other birth control, it suppresses gonadotropin. Oh, so you don't release that.
No gonadotropin release, so no FSH, no LH.
So you're not ovulating?
Yeah. Some of these don't, no ovulation, right? Depo-Provera.
Oh
You don't-
yeah, but then I thought they
You don't
want-
menstruate, right?
Yeah.
Because there's no thing to menstruate. No follicle development.
I thought on the pill you still menstruate.
Some pills you
Some
use,
pills
some
do.
pills you don't. And
Yeah.
it depends on how you take them.
Mm.
I never did the pill.
And
but-
some IUDs have these embedded in, so they're leaking progesterone all the time.
Huh.
Yeah. Then there's this other one, human chorionic somatomammotropin. Don't you love that word? Somatomammotropin. I love this part.
What was it?
Not related to placental lactogen,
Human chorionic.
right? It's released from the placenta. And once the placenta starts get going, which at week 5 is pretty minimal, the most important part about this, it's not well understood and it has nothing to do with lactation in animals or humans,
Huh.
as it does in other animals, but it does have some influence on insulin and insulin sensitivity. And so this human chorionic somatomammotropin is going to cause the female to produce more triglycerides. Why would you want more triglycerides? Well, because you want to provide an energy source for your fetus to grow. Why else? If you have plenty of triglycerides, that means that the glucose can be diverted to the fetus. So you use the triglycerides for energy rather than the glucose. And this, as it says here, has important implications for what disease in pregnancy.
Gestational diabetes.
Gestational diabetes, exactly right. Losing that sensitivity to insulin.
Mm.
Yeah, yeah.
Do we have to remember that big long word?
Somatomammotropin?
Somatomammotropin.
You can't remember that one, Lindsay? It's so cool. Just say it a few times, somatomammotropin. What happens when a woman is pregnant? Well, everybody's familiar with morning sickness. You've all heard that women develop morning sickness. Not all. Some more, some less. The degree to which is dependent on the individual. They believe that this nausea has something to do with changing the appetite and making spicy foods, things that may impact the developing fetus, less desirable. And so they think that this is a big part of saving that embryo so it stays intact. Some women develop this. Have you heard of hyperemesis gravidarum?
Mm-hmm. Just constantly
Constant.
vomiting.
Constant morning sickness throughout the entire pregnancy. Some women are so impacted they can't get out of bed. And I know of one woman who lost her pregnancy because of it. Yeah, I've met several. And one woman was pregnant while she was taking my class during COVID, and some days she's like, I just can't. I'm sorry, I just feel so ill, I can't even step for class, yeah.
They do. They have a medication that they give people with hyperemesis. Yeah.
They used to give women, here's a great question. So have you heard of thalidomide?
Yeah.
Thalidomide was this wonder drug in the 50s. In the 50s, they were giving pregnant women thalidomide to tamp down morning sickness. But guess what those women started producing?
Deformed.
Babies with deformed limbs.
Yeah.
Yeah. So thalidomide, out of favor for morning sickness, but guess what? They've discovered that thalidomide actually has some antiviral and cancer-preventing attributes. So not to be given to a woman who's pregnant, but if you have cancer and thalidomide's the drug of choice, you could do that.
Miracle drug is always.
You know, like Zofran?
Yeah. Suspect.
What?
Zofran.
No, I haven't heard of it. Never been pregnant, never.
Zofran,
I take that back, I have been.
recently they started
But no,
giving, pregnant people Zofran.
Yeah, okay.
So that is allowed now,
Yeah.
but that's really recent.
Okay. Some things that happen to a woman that's pregnant, constipation, as you might imagine. If you have that pressing against your intestines,
Gee, I wonder why.
I wonder why, yes. GERD, heartburn, what's GERD? That's gastric juices being squeezed from your stomach up into your esophagus. I wonder why. Your basal metabolic rate increases 15%. I wonder why. Look at the number of calories you have to burn to support this growing Some people consider it parasitic.
I mean, it kind of is.
It
It's
kind of
stealing
is.
your nutrients from your body.
Remember
Like,
that video, the guys, the nerds singing Mother's Day song?
Yeah.
Lived off your rent free. Yeah. So
Generally,
you can
well,
gain as little as 24 pounds where you never even noticed you were pregnant,
Right.
to as much as 75 or more, depends on the individual again. Your placenta is super important. The placenta is the link between you and that developing fetus. Everything has to pass through the placenta to get to the fetus, and from the fetus to the maternal blood. And at the end of pregnancy, the placenta is what's known as the afterbirth, and that has to be shed. If it hasn't, then you have to go in and get it out. You got to go in and get it out. Other things that happen. Blood volume rises by 30%, and as a consequence of that, that means that you're going to have an increased blood pressure. That makes total sense, doesn't it? Increased hematopoiesis, making more blood cells, because you got to keep up that blood supply to make sure that that fetus has everything it needs, because it's all being carried through the maternal blood delivered to that fetus via the placenta. There is an increase in blood supply, and that increase leads to things like varicose veins and hemorrhoids, because now you have this enormous amount of blood. Plus, the blood that's coming up from your legs has to get through here. Do you remember talking about the respiratory pump
yeah.
when it comes to breathing and moving blood? Well, that respiratory pump isn't working so well because you got all
You've got
this
a giant
pressure.
thing in the way.
I know. So this leads to the varicose veins and the hemorrhoids. A respiratory rate that increases 40% because, well, obviously oxygen demand is huge. Got to deliver all that oxygen to the developing fetus. You have to think about breathing because you can't just simply drop your diaphragm automatically. You got to really think about inhalation now. Progesterone causes chemoreceptors to be more sensitive to CO2. This is fascinating. These chemoreceptors more sensitive to CO2 means that you can get rid of that extra CO2 from the fetus, not from the maternal, because maternal partial pressure of CO2 is dropping so that the CO2 in the fetal blood has room to diffuse down its concentration gradient. Totally makes sense. Last but not least, pregnancy can result in increase in weight gain. Everybody knows about that. Pregnancy can lead to your increase in your glomerulofiltration rate. Why?
Remove waste.
Because you have so much more waste product to get rid of. Absolutely. And it can lead to incontinence. I wonder why. Here's your bladder.
Yeah.
There it is. What else? Stria. So you get stretch marks. That's what stria is, stretch marks. You can get a melanization of the linea alba as a result of those hormones. And your areola might get a little darker.
Big dark line.
And you get, as it says here, distribution of your weight gain because of these structures right here. And that, my friends, is the end of the female reproductive system. Any questions? Comments? Yes?
With HCG, the
Human chorionic gonadotropin?
Yes.
Or, yeah, human chorionic.
HCG,
Uh-huh.
when you have low levels, is that when you get a false negative?
So your false negative can happen for a couple of different reasons. Obviously, the test has to be in good condition.
Yeah.
And you can always have false negatives, false positives, and virtually any test like that.
Yeah.
Maybe you didn't hold it under the stream long enough. Maybe you didn't wait long enough. Maybe you waited too long.
What about in ghost pregnancies where they take like 10 pregnancy tests, they're not showing, they have their period? Do they still have those HCG level?
Yes.
Do they? You know this. I think you've been through this. Yeah. She's the expert because I haven't been there.
No babies.
Okay, I'm gonna let you go.